Good morning, everybody, and welcome to the morning symposium. It's my pleasure to introduce Dr. Thomas Alexander, who is a homebred. He was trained in CMC as undergrad, his medicine training, and subsequently DM cardiology. And he worked as staff here as well as a lecturer in the capacity of a lecturer, and moved to Australia for his fellowship. Since his return, he's been based in Covey Medical Center. It's a tertiary care center where he's an interventional cardiologist. He's a noted figure amongst us and to us as the Department of Cardiology in Vellore. He's been a senior mentor and a well-wisher. And to us from the home, he is the father of Vineet, who is doing his DM critical care, and Kirtana, who is a PG in the obstetrics and gynecology department. Professionally, Dr. Thomas Alexander is known as the father of the STEMI program in India. So his initiative, along with Dr. Ajit Mullasheri, dating way back to 2010, has made steady progress to the extent it's a global entity now, where sort of practices what he preaches in terms of equitable distribution of healthcare. Come the challenges of a global, the African nations, the Latin American nations, and West. We know there's a gross disproportionate resource and a financial disparity. Coming home in India, there's a big north-south divide, and then the rural and the urban divide. So to address all this, I'm happy to call upon Dr. Thomas to take us through over the next 30 to 45 minutes. Thank you.
Thanks, Vijay. First of all, let me thank Anand Zach for this invitation. What I'll try to do over the next 15 minutes is to quickly walk you through a model that we've developed, which we believe is a homegrown model that is appropriate for a low and middle income country. And let me start with why did we start with it? Now, if you were to look at estimates of STEMI in India, this is compared to, say, US data or European data, we estimate that about 2 to 2.6 million patients have MI in India every year. And what is peculiar about STEMI presentation or ACS presentation in India is that almost 60% of ACS in India present as STEMI. This is unlike Western data, which is only about 25 to 30%. So clearly, ST elevation myocardial infarction is a major issue constituting close to about 1.2 million patients every year. Add this to the problem that we have in India, where if you look at Western populations, less than 45 years of age, you would have about less than 4%, 5% of patients presenting with MI. Our data, both from Tamil Nadu and from other states where we've run programs, it constitutes between 20 and 25%. And therefore, if you look at the socioeconomic costs of this illness, you can see that they're massive. Now, this is data from the CREATE registry, and you can see if you divide them into the upper middle class, the rich, and the lower middle class and the poor, you can see that the better modes of reperfusion, whether coronary angiography, PCI, or CABG, occur much less in the poorer population, and that's reflected in mortality rates, which are much higher for those from the lower socioeconomic and the poorer classes. Women are a disadvantaged lot when it comes to STEMI, and we've shown that they present later. And if you look at both in-hospital mortality as well as one-year mortality, they're almost 2 times as high as mortality in men. And there are reasons for this, and we need to focus on this population. Now, we've looked at data across interventional cardiology as well as thrombolytic doses that are instituted in India. And only about 40 to 50% of patients in India get reperfusion therapy. And if you look at rural registries, and this is Himachal registry, you can see it's only 35% of patients with STEMI who get reperfusion therapy. So there's a huge need. So what are the challenges? There's a huge burden of disease with less than 50% receiving reperfusion therapy. 70% of those who receive reperfusion therapy get only standalone lysis. And you know that if you take the various ways of reperfusion, whether it's primary PCI, pharmacoinvasive, or standalone lysis is probably the least effective of the lot. And 70% of our patients get only that. 20 to 25% are below 45 years. The lower socioeconomic strata receive less of primary PCI and pharmacoinvasive, and consequently have a higher mortality. And women have twice the mortality as men. And these are the challenges. So it was in 2010 that Dr. Ajit Mulasiri, who is the director of cardiology at Madras Medical Mission, and I, we sat together and we said that we need to set up an organization that would focus on STEMI to see, can we find solutions that are homegrown, that are practical, and that can be implemented across the country. These are publications in 2010, 2011, when we first said, is it time for India to have a system of care? This was published in British Heart, and we had certain consensus statements along with the major cardiology society, association physicians on how to take this program forward. Now, the initial validation study was done with funding from the Indian Council of Medical Research, where we looked at combining the pharmacoinvasive with primary PCI in a hub and spoke model. So if a patient presented to the hub, he would get primary PCI. If he presented to a hospital in the periphery, he would have thrombolysis. And then the window of opportunity would be wider. So you had 3 to 24 or 2 to 24 hours to move this patient to the hub to complete the invasive procedure. The initial validation study was published in JAMA Cardiology. This is in 2020, and CMC Vellore was one of the centers which was part of this landmark trial, which is now the basis of the STEMI program in many countries across the world. What we did, I'll just show you a case to illustrate this. This is the Coimbatore cluster. When we say a cluster, it's the hub hospital with the spokes that are linked to this hospital. So here's an actual patient. This was taken on the smartphone of the driver of the ambulance. And this is the paramedic doing the ECG. Now, we developed a certain IT, both hardware and software, so that a patient who calls an EMRI, so they were one of the collaborators with us. A patient developing chest pain, ECG done in the ambulance, transmitted to the hub hospital doctor for confirmation. This is the ECG showing an acute inferior infralateral MI. Patient taken to a hub hospital where he thrombolized. ECG showing incomplete reperfusion. Moved to the hub hospital. You can see that it's a critical stenosis, stented. And this is the patient at the end of this. The whole process was linked to the health insurance scheme. And this is the first time a health insurance scheme was linking both thrombolysis, transportation, and primary PCI or a pharmacoinvasive treatment within the same insurance program. And we were able to ensure that the poorest of the poor could access STEMI care and what we would say is the best-in-case management. In a period of 9 months, we were able to show a 3.4% absolute reduction in mortality. And what really changed was that pharmacoinvasive treatment, which was 0.5% when we started the program, went up to 30%. But what is also important is if you look at this, in the rural hospitals, which were spokes in this program, there was no linkage to the health insurance scheme, but about 60% of patients who came into the scheme were scheme patients who had no payment to be made, who were able to get thrombolysis, were able to go to the hub hospital, get a PCI, and get the whole medications also underwritten by the insurance scheme. We did a cost-benefit analysis. This was with IIT Madras, which showed that a 3.58 for every rupee that was spent on this program, there was a 3.58 rupee benefit. So not only were we showing mortality reduction, we were showing that it was cost beneficial. We realized that there were 5 key aspects to this. primarily what we realized is that collaboration with the government was absolutely important because they were providing the ambulance services. Government hospitals were involved in the program. The health insurance scheme was run by them, and it was imperative that it was linked with the hospitals so that the whole process was paid for by the patient. We also had hardware and software which we had developed and which is now available to every state to use in their programs. This was then taken up by the Indian Council of Medical Research. They had a dissemination meeting where the results of the study were discussed with principal secretaries in different states and encouraged to take it up. It became a national health mission program. And there are numerous publications to attest to this. Now, we started this with a hub and spoke model where we thought we would do primary PCI and pharmacoinvasive, but we soon realized there were multiple states which did not have cath labs that could provide pharmacoinvasive or primary PCI. And therefore, now we've modified this to look at 3 separate models. Model 1 is purely, we're going from no reperfusion to just thrombolytic reperfusion. These would be in states. I'll show you some data on that. Model 2 is the classic model that we ran here in Tamil Nadu, which is now being taken up with multiple southern states. The third model, then this we're running in Cairo in Egypt, which is very much a US or a European model where there are multiple cath labs that are available, all linked to hospitals outside where patients present with a STEMI but are moved immediately to the hub hospital for primary PCR. Now, where is Tamil Nadu, where we initially started, moved on from there? And this, I must congratulate the Tamil Nadu Health Initiative because they have taken the learnings of our pilot project, and this is what they managed to put in place. The STEMI has become one of the pillars of their emergency care. Ambulances, cath labs, training, and a STEMI coordinator have been put in place, and these are all in government institutions. Ambulance services have been ramped up. Cath labs in the government sector, which was 1:25 in 2013, has become 1:5 and is now 1:4. And this is because a state like Tamil Nadu could invest in cath labs and have a large pool of cardiologists in the government sector who can run these programs. And this is the last few months. If you look at the data, the number of STEMI that have been managed every month in the areas where the program has been running, it's about 1,500 STEMI patients a month. But this is still being ramped up in certain other parts of the state. Now, this is what we did in Jharkhand, where we ran the program. We found that there was only one cath lab in Ranchi, and none of the district hospitals were even thrombolizing. And we realized that what we need to do there is model 1, not model 2 or model 3. What we did was to set up ECGs in each of these district hospitals, train them in thrombolysis, and then start with thrombolysis as moving patients from no lysis to at least thrombolysis. And this is where you see the number of ECGs going up steadily in these district hospitals and tele-ECG being a part of it. And the programs currently in a small or large way is being implemented mostly in the southern states and a few northern states. We now have a unified strategy for the success of this program. And these are the learnings from this, which we now emphasize when we take this program to different states or different countries. What are the new initiatives? And this is a new initiative that we are now working with the central government on. This is to look at an integrated emergency model system where we're trying to combine STEMI, stroke, trauma, obstetric emergencies, burns, and acute respiratory distress in the public hospitals, that is in primary health centers, community centers, and district hospitals. And this will we will be running it in 8 districts in the country in the coming 2 to 3 months. And this is going to be a pilot program, which eventually, if successful, can be run across the country. The third initiative is to start chest pain clinics, and we realize that this is a need of the hour. And in the next 2 to 3 months, we hope to start chest pain clinics as a pilot. We hope that in the next 3 years, we will have close to about 1,000 chest pain clinics in different parts of the country. And we hope to ramp that up quickly because we realize that one of the major issues is patients with chest pain going to hospitals which have no capability of handling chest pains and miss the diagnosis and lose that critical time when reperfusion should happen. This is an editorial by Bernard Gersh from the Mayo Clinic who wrote that this is a model that would ultimately be something for low and middle income countries. Where have we moved in the international sphere? Now, Stent Save a Life is an organization that's part of the EuroPCR based in Paris, and it's a worldwide, it started as a European initiative for STEMI programs in Europe, but now has moved to countries outside Europe. Now, SSL has signed an MOU with STEMI India to utilize the protocols, the training, and the digital tools for use in low and middle income countries. So we provide all the expertise for this organization to run these programs across the world. I co-chair this global team, which is a Paris-based organization, but the advisory board is purely a European who's who of cardiology from Europe. We have representation in all the major continents, and there are programs that are now starting in all the major continents based on the study and on the model that we developed here. At the moment, there are programs that we're running in South Africa, in Sudan, in Egypt, Peru, and Azerbaijan, and there are many more that are in line now. Now, what have we achieved? In the last 10 years since we started this organization, we've been able to bring STEMI management to center stage, a long ignored time-sensitive emergency. Now, cardiology meetings across the globe talk about systems of care for STEMI management, while as part of their major meeting, because they realize that whatever else that we may do, unless you have these systems in place, you cannot take the program forward. Our pivotal study is now being considered as a global model for low and middle income countries, and governments both in India and LMIC believe that it is now possible to run a STEMI program in a country with limited resources. What we've also done is to give our protocols, our digital tools, and the training material to ICMR to utilize in any of the government programs that are currently being started. And you will see that Andhra, Telangana are using these protocols going through the ICMR because there's clearly the government-to-government agreement is possible. What we need to achieve, I think, is a significant amount of public education to make sure that the high-risk groups, particularly women, are targeted. Southern states have been fairly eager to implement these programs. And in fact, in Andhra, they're looking at a public-private partnership, which is a great thing because I think as infrastructure in the government sector builds up, we need to use the spare capacity that is available in the private sector. And once it's linked to, say, Ayushman Bharat or one of the state health insurance schemes, equity is maintained and one can be sure that the target population is also able to access care. States from the north and northeast are the most difficult to get onto the program, and there the need is the greatest. So again, to those of you who work in these areas, talk to your governments. If you can push your governments, the protocols are available, the money is available. All you need is the will and the people to take this program forward. And newer concepts are being trialed, comprehensive emergency care, chest pain clinics, and we believe that these will all take acute coronary syndrome care to the next level. Thank you.
Thank you, Dr. Thomas, for that excellent overview. For people who came in late, or I think some of the terminologies I understand may not be very colloquial in the other domain other than cardiology. So if you could just elaborate on primary angioplasty and what pharmacoinvasive is to, and I mean, different people from different stratas are here. So if it's for their benefit, and
Yeah.
what exactly is the, in terms of mortality, morbidity, the difference?
Yeah, so sorry, when you talk about reperfusion therapy in an acute heart attack, we talk about the golden hour. If you're able to reperfuse an artery within the first hour, in about 30% of patients, you can even abort an MI. So you don't even see a trace of an MI in these patients. So the earlier, the better. And the guidelines would say 12 hours is usually the time when you're going to have any significant reperfusion benefit. Of the three ways of reperfusing, the first is the thrombolytic. That's using a clot dissolving medication like streptokinase or the newer ones, tenecteplase or retiplase. The reperfusion rates, or to me, the good flows are about 60 to 70%, but there is a significant reinfarction and re-ischemia in this population. So if you lead them, as you saw in the first patient, after the infarct, it looked like even though he had no pain, the residual lesion in the coronary artery was still almost 99%. And if you sent him home, he would go home maybe 2 or 3 days, have a reinfarction and die at home. The second way of doing is what we call pharmacoinvasive, where you thrombolize, but within 3 to 24 hours, you move him for an angiogram, confirm that the artery is open, or if it is still occluded, you might want to do an angioplasty at that stage. The third is primary PCI, where you open the artery with a balloon angioplasty. If you look at in-hospital mortality, it would be about 8% with thrombolysis. It'd be 2% or 2.2% with pharmacoinvasive, 2% with primary PCI. So the pharmacoinvasive is almost as good as primary PCI. And combining these two, we've combined the best of the reperfusion modalities, but in a way that is practical, because we then get time thrombolized, and then you have almost 24 hours to move this patient to a hub hospital, which is practical in low and middle income countries.
Any questions from the floor? Please.
Good morning, sir. It was an honor to listen to you speak, sir. I'm a faculty in medicine from Pondicherry. I had a quick question. Sir, you happened to mention about chest pain clinics in the future. So I wanted to know what services you would offer, which target population do you expect it to be catering towards? Would it be another spoke, or will it cover post-PCI rehabilitation and follow-up as well?
See, I believe that the greatest good can be done if these are government programs. And we've been working exclusively with governments to try to take the program forward. And this is because most of our patients go to public hospitals rather than, the poor go to public hospitals rather than to private hospitals. We are now realizing that a substantial number of population would be excluded from a program like this if the private sector is not included. And the chest pain clinics that we are starting would be more targeted at private hospitals or private clinics, and then try to build a STEMI program from that. So we're looking at starting at that level and then building it upwards.
I would like to share our experience. We've been having a chest pain triage unit parallel to the cardiology, casualty for the last 8 to 10 years. The idea here, like Sir said, is to expedite treatment. See, like door to needle time. So like a patient who administered a lytic therapy happens in the around 10 to 15 minutes once the patient is in triage. Samely, now since we moved to Ranipet, we are in the same floor. We have the chest pain unit and the cath lab. So provided finances are there, you're looking at opening the artery in less than 30 minutes. So it's more of expediting care for the patient. Time is muscle towards that end, if I understand right.
Correct. So what we would have a tele-ECG and a point of care troponin, because we want to pick up the ACS in its whole entirety. So the non-STEMIs are also picked up in the chest pain clinic.
Any more questions? Uday.
Good morning, sir. I am a hepatologist from CMC. As I understand that this was a hub and spoke model for acute care of a chronic disease. I just want to know in retrospect, what was, in your opinion, your biggest challenge over the years? And going forward, what you anticipate would be one of the challenges?
Well, I think getting a government on board is probably the most difficult. I mean, we tried this for many years. You know, you go to a state, explain what the program is. One of the things that you need to understand is funds is available already. In fact, when we talked to the National Health Mission, what they told us was there's 2,000 crores set apart as innovation fund every year, which is never utilized. So if a state government can be induced to start a program, funding is readily available. The tools are available. The protocols are available. It's just that we do not have the commitment, especially from the North and Northeast, and where the need is the greatest. And this is something that's so frustrating. And this is why we finally said, let's give this program and all these things to ICMR and see if they can push it, because we found that you go and sit with the secretary. Yeah, he says, yeah, come on so date for a meeting. You go there on that particular date, you fly to, say, Guwahati. And he says, today the minister called me, I can't see you today, come tomorrow, and that's the sort of attitude that the bureaucrats had. They don't want to do new programs. Or if there is a transfer of a bureaucrat, you need to start from scratch again. It's just so frustrating, I think. Sorry. Yeah, so treatment is the standard treatment. We this is putting the whole. We're not reinventing anything that is not already known or available. The antiplatelets are the same, the lytics are the same. So all we're trying to do is to put the different pieces together to make sure that the patients with chest pain gets reperfusion as quickly as possible.
Hello, sir. My name is Philip. I'm an endocrinologist. I have worked in Odinchhatram as well as in Bihar, in Roxol. As part of the distance education program from CMC, I was involved in capacity building for the government doctors in Bihar for many years. And the biggest point I found, one of the obstacles was doctors are scared of using the ECG machine because they don't know how to interpret. So my role for 5 years was teaching them ECG interpretation. And at the end of 5 years, there were only few doctors who told me, now I've dusted my ECG machine in the PHC and a secondary and I'm using it. So they are scared of giving a thrombolytic agent because they feel if there is a complication, their patients they'll be mobbed and there will be fear. So fear was a major factor I observed when I discussed and had multiple sessions. Why can't they use the ECG machine in the secondary?
No, I think this is a great point, because invariably, so we had a coordinator in Jharkhand who would go every week to every place to make sure that the locks where the ECG machine was locked and kept was left open. But what you say, I mean, no amount of education is going to teach people how to use an ECG or to read an ECG confidently enough to thrombolize. So they may look at the ECG and say, yeah, this is probably STEMI. This is why I say tele-ECG is absolutely essential, because what you're doing is you're hand-holding them, saying, yes, this is a STEMI. You suspect it, but we're confirming that now for you. Go ahead and shoot the thrombolytic. So I think your classes are okay, but finally, because, okay, an MI goes to a primary health center maybe 3 or 4 times in a month, not enough to keep your skills intact for you to confidently say, I'm going to lyse this patient. So tele-ECG is a starting point, and without that, you cannot run a STEMI program.
Thank you, sir. This is Aditya, Community Medicine Junior Resident. Sir, I came across EECP. So is there any utilization of this EECP along with the program that you are running in the future?
EECP, did you say?
Enhanced external counter pulsation, that is
Okay,
non-invasive.
So that's a very limited role in people who have no other ways of revascularization, not in an acute situation. So this is Usually people with diffuse triple vessel disease that you might try, there is some data to support that, where angioplasty or CABG is not feasible, but not in an acute situation. If you're talking about preconditioning, that's a different thing that you're talking EECP. It's in end stage coronary disease where no other form of revascularization is feasible. It's not the STEMI patient that you're talking about.
Thank you, sir.
I don't see any questions in the chat box. Thank you, Dr. Thomas, for that excellent talk over the last 30 minutes.
Thank you, Dr. Thomas. We would request Dr. Vijay Samuel to please felicitate Dr. Thomas Alexander. Thank you. We would request Dr. Thomas Alexander to please come in front and receive a memento on behalf of our institution. Thank you very much.